they had references on this iris topic. Out of the 10 references that were on the slide, 6 of these were your articles. So colleagues, I am not going to read Prof's profile. I think you understand what I mean on this topic. We have one of the best in the world to take us through this particular topic. Let's give Prof lots of love and welcome him. Prof, you may take us from here. Thank you.
Great. Thanks, Lesego, and thanks for hosting me on the platform once again. I really
Yes.
appreciate it and really appreciate the turnout this evening. I know everybody's probably had a long, hard day's work, but to come and listen to a talk about iris, which is a topic that has fascinated me, really appreciate the interest that everybody's shown, and hopefully we'll have a good engagement this evening. So what I want to do is just share my slides first. Lesego, that's coming up fine, huh?
Yes, it's perfect. Thanks, Prof.
Yeah, okay. And so I intend to address the issue of immune reconstitutional inflammatory syndrome, which is known as iris for short. The majority of the talk is going to be focused on TB iris, but there are a few slides at the end just to discuss some other conditions which can manifest as iris. So I wanted to start off with a clinical case scenario that just illustrates one of the common presentations of iris, of TB iris. It's a very heterogeneous condition. People present in many different ways, but this is one of the most common presentations. 38-year-old woman living with HIV. Previously, she had been on ART, but had disengaged and returns now with TB symptoms and is diagnosed with pulmonary TB on the basis of a sputum expert that shows MTB and is RIF sensitive. At the time of the TB diagnosis, she's noted to have 2 centimeter lymph nodes in her left neck. But they're not causing any symptoms. That's just on examination. And she starts TB treatment based on the diagnosis and reports that her symptoms are improving. CD4 count is found to be 78, and she starts TLD 20 days after starting her TB treatment. So roughly 3 weeks delay between TB treatment and ART. And she's seen 2 weeks later, she reports that the night sweats that had got better have returned. Her cough that had got better has also returned. Just 1 week after starting TLD, her TB symptoms have come back. She says, and patients often say, this feels like I'm having a second episode of TB. But what also happens is she gets progressive enlargement of those lymph nodes, which were relatively small lymph nodes in the left neck. They now progressively enlarge over the next few weeks to become a massive lymph node mass with prominent acute inflammatory features. So they're tender to palpation, painful when she moves her neck, and red overlying skin. And gradually, this firm lymph node mass breaks down and separates such that it becomes liquefied pus in the lymph nodes. And that's just an image of a patient with a TB iris lymph node in her left neck. And you can see 2 lymph node masses, and the bottom one with very prominent acute inflammatory features, tense red overlying skin, very tender to palpation. Patients often find that these are very symptomatic. And what with TB iris of the lymph nodes, often the first few weeks it's a solid fluctuant, and you can aspirate pus from it. So we'll come back to discussing TB iris lymphadenitis, but that was just to give you some a clinical case as an introduction. So what's the clinical context in which iris occurs? What is important to appreciate is when patients start antiretroviral therapy, but if they start with a very high viral load in the tens of thousands or in the hundreds of thousands, we know that if they're on an effective regimen, which is usually 3 drugs, sometimes 2 drugs, and they take that with good adherence, they get a predictable rapid drop in viral load. It's a kind of biphasic phenomenon. The first drop is very dramatic, and then a more gradual decline to being undetectable by 3 to 6 months. and it can be faster with dolutegravir-based regimens. But that first rapid drop in viral load is by 1 to 2 log 10 over the first 2 weeks of antiretroviral therapy. And this is an old study just showing for 3 different regimens a predictable drop in viral load. So 1 to 2 log means a 90 to 99% reduction in viral load in the blood in just the first 2 weeks. And we know that what happens with that rapid drop in viral load in just the first week or 2 of antiretroviral therapy is it allows a recovery of CD4 count. And this is again just showing 3 different regimens. It's an old slide, but just for illustrative purposes, 3 different regimens, similar rises in CD4 count over the first year of antiretroviral therapy. And on average, over the first month of antiretroviral therapy, the CD4 count rises by 75 cells, patients who start with a low CD4 count, and then by 75 cells over the next year there afterwards. Obviously, those are people who start with a low CD4 count, and there is variability. This is just the average. But it's in this context of early ARVs in the first few weeks of antiretroviral therapy, there's this rapid drop in viral load, an early recovery in CD4 in the blood, but more importantly, there are substantial improvements in immune function within the first few weeks. It's not just a case of the CD4 count rising. The drop in viral load allows improvements in immune cell function, not just CD4s, monocytes as well. The innate immune system starts functioning better. And it's in that context of early recovery of immune function that we see IRIS occurring. So what is IRIS? IRIS is essentially antiretroviral in the context of HIV. We see it in other conditions, under the conditions like recovery from immunosuppression, but in the context of HIV, it's starting effective antiretroviral therapy that potently suppresses the viral load replication. There's a rise in CD4 count. There's also improvements in immune function generally. And that leads to restoration of pathogen-specific immunity, so the ability of the immune system to respond to specific pathogens. I put CD4 count rise in brackets because sometimes we see IRIS even before the CD4 count has risen because of the other aspects of the immune system recovering or because there's been improvements in tissue immune function. Now, this restoration of pathogen-specific immunity is obviously what we're aiming for, because the positive spin-off of that is you get regression and prevention of opportunistic infections. And we know that once people have immune reconstitution on ART, that in itself prevents conditions like PCP and cryptococcal meningitis. Some conditions like cryptosporidial diarrhea will improve just with antiretroviral therapy alone, even though there's no specific treatment for the cryptosporidial diarrhea. So there's real positive benefits of the immune recovery on antiretroviral therapy. But the flip side is the negative aspects on the right-hand side there. That recovering immune function, the first few weeks of ART, can drive inflammatory reactions. And those inflammatory reactions are termed IRIS. So in the context of TB IRIS, essentially, this is a slide just elaborating on what I showed in the previous slide, the suppression of HIV replication on ART, early reversal of immune suppression systemically and at a tissue level. And that can drive inflammatory reactions. In the case of TB IRIS, those inflammatory reactions are targeted at TB antigen at the sites of TB disease, be it in the lung, be it in the lymph node in the patient that I showed you. And that inflammatory reaction then drives clinical deterioration with local inflammation and often systemic inflammation as well. And in TB, when we think about TB IRIS, there are 2 broad forms of TB IRIS. And the one that our group has really studied is the first one, paradoxical TB IRIS. So paradoxical TB IRIS refers to patients with HIV who are diagnosed with TB, start TB treatment, and then after starting TB treatment, and they're typically improving on TB treatment, then start antiretroviral therapy, and then deteriorate as that patient that I showed you deteriorated. So the sequence is people have HIV, they're diagnosed with TB, start TB treatment, start ART, and then develop an inflammatory reaction, and that's paradoxical TB IRIS. The other form of TB IRIS is patients who have HIV, are not recognized to have TB because the TB is undiagnosed and often symptomatic, but it's because of the difficulties in diagnosing TB, it's not diagnosed. They start ART, Some of them will develop TB that has a usual presentation, but a subset, and that's why the blue box is within a bigger white box, a subset will develop particularly inflammatory presentations of TB that might present like a bacterial pneumonia with respiratory failure and driven by the severe inflammation, and then we call that unmasking TB-RS. But the one that I'm going to really focus on this evening is paradoxical TB-RS. So what are the clinical features and the clinical characteristics of paradoxical TB-RS? We know that across studies, there's a wide range of prevalence incidence estimates. So one study reported that just 4% of patients on TB treatment starting ART developed TB-RS, whereas another study, it was over 50%. But on average, in a meta-analysis, 18% of patients starting ART while on TB treatment develop IRIS. Obviously, if they've got risk factors, it'll be higher than 18%. The typical onset time, the average time to onset is 14 days after starting ART, with an interquartile range of 7 to 21 days. So it's typically within 1 to 3 weeks, the onset of symptoms. And although TB-RS causes a lot of morbidity and a lot of symptoms and concern for the patient and the healthcare worker, mortality is due to TB-RS is relatively infrequent. It's about 2%, mainly when the central nervous system is involved. And I'll show you one case of a patient that died from TB-RS involving the brain. But many patients require hospitalization. In this meta-analysis, it was a quarter of patients required hospitalization. So just to go back to the sequence, paradoxical TB-RS, patient has HIV, they're diagnosed with TB, they start TB treatment, they then start ART, and then they develop the inflammatory reaction. And this is just showing you a sequence of chest x-rays of a patient that I looked after many years ago. Diagnosed with TB in the first chest x-ray, what you see is large mediastinal lymph nodes and right-sided pulmonary infiltrates. Patient then starts TB treatment, and you can see in the middle chest x-ray, there's been substantial improvement. Then starts ART and presents with recurrence of respiratory symptoms and night sweats. And you can see that the right-sided infiltrate is a lot worse. So that's a typical case of paradoxical TB-RS, improving on TB treatment, deteriorating with inflammatory features after starting ART. And these are just some other examples of pulmonary TB-RS, which occur, 40% of patients with TB-RS have pulmonary involvement. You can see the top panel, the patient A, patient's chest x-ray known with TB at the time of starting ART, starts ART, develops TB-RS, recurrent symptoms and worsening pulmonary infiltrate. So the original area of infiltrate in the left midzone expands. On the second patient in the lower panel, you can see the patient at the time of ART initiation has right-sided mediastinal lymph nodes and hilar lymph nodes, and then starts ART, develops worsening TB symptoms and much larger lymph nodes in the mediastinal and the hilar area. So he has lymph node involvement in the thorax. And this is another patient with peripheral TB-RS lymphadenitis. Patient started TB treatment, started ART, then came to see us at the secondary hospital with these massive lymph nodes, and it required recurrent aspiration of those lymph nodes. I remember once taking off 50 mils of pus from those lymph nodes, and you can see that the tuberculous pus on the slide. And just to really at this point emphasize that this patient, we did multiple aspirates of his lymph nodes, and they were repeatedly AFP positive, smear positive, but TB culture negative. So this didn't reflect failure of the TB treatment. The AFPs are reflecting likely dead mycobacteria. What this is reflecting is an inflammatory response directed at those mycobacteria that were still present in the tissue because he was TB culture negative repeatedly. So the deterioration is not due to failure of treatment. It's due to the inflammatory response driven by the recovering immune system, immune function. And this is actually the same patient this man had a TB iris that went on for over 2 years. He developed those lymph nodes in his neck, then he developed a cold abscess on his chest, and then later on a psoas abscess. And you can see it on the CT scan here. That's the normal psoas muscle on the left-hand side. That's the right-hand psoas with abscess within the psoas, probably developed from some lymph nodes initially. And then this massive abscess here, the size of a rugby ball, in his abdomen. And we repeatedly drained pus from that, which was, again, AFP positive, culture negative on repeated occasions. And, eventually, after having multiple TB iris manifestations at multiple sites sequentially, his TB iris resolved completely. Now, the most life-threatening form of TB iris is when the central nervous system is involved. And this can take various forms. The features include new or recurrent TB meningitis. So patients who've been diagnosed with TB meningitis, started on TB treatment, they're getting better. They can come in with a recurrent episode of meningitis due to this inflammation in the meninges. The other scenario is patients diagnosed with pulmonary TB. You start them on TB treatment and then ART, and they can present with meningitis for the first time due to iris. And this is presumably because there was subclinical involvement of the meninges, and now with restoration of the immune function, they develop inflammation due to TB iris. The other manifestation is enlargement of tuberculomas or formation of tuberculous abscesses in the brain surrounding cerebral edema, and then radiculomyelitis, which is a complication of meningitis, inflammation around the lower spinal cord and the lumbosacral nerve roots, typically, that causes a paraparesis and can give permanent paralysis. As I said, this is one situation where mortality can be substantial when the brain is involved and can leave patients with neurological disability. So I want to show you one really tragic case of a patient who developed a neurological TB iris and died from neurological TB iris, despite our efforts to intervene. And I think this just illustrates the far end of the spectrum of TB iris. I'm not suggesting all cases are this severe. Some patients, it will just be a return of night sweats and a cough, and it'll be short-lived. This is the most life-threatening type of TB iris. It fortunately happens in a small minority of people. So this was a 32-year-old woman, HIV positive, CD4 count of 26, had never been on ART. And she presented with headaches and neck stiffness. Lumbar puncture was done, was suggestive of TB meningitis. That was a chest X-ray at presentation showing the right upper lobe infiltrate. She was started on standard first-line TB treatment and prednisone. And she had a good initial response to treatment, was discharged. The family reported she was doing well and able to perform self-care at home. And then she went to the clinic. 6 weeks later, she was started on ART, 6 weeks after starting TB treatment. And she presented back to the secondary hospital 2 weeks later after starting ART with generalized tonic-clonic seizures. After the seizures had been aborted, she was still at a depressed level of consciousness with a GCS of 9/15 and a marked right-sided hemiparesis. And you can see her CT scan showing this massive tuberculoma with severe surrounding cerebral edema and midline shift and a compression hydrocephalus on the left-hand side, on the right-hand side. So what we did was we treated her with very high doses of dexamethasone, anticonvulsants. We also stopped her ART, but despite that intervention, she died 2 days later from TB iris. So, a very unfortunate outcome. I'm not saying that all cases of neurological TB iris patients have a fatal outcome, but it is more common. And the treatment is usually with a high doses of steroids. And sometimes in some patients, we might stop the ART. Whether that does benefit or not, I doubt it, but only if it's life-threatening. Some other examples of TB iris, what can happen is that effusions can enlarge or form. So the top panel, these are two separate patients. The top panel was a patient who had TB pericardial effusion, and this was at the time of starting ART. The effusion had resolved on the left-hand chest X-ray, still had some right-sided mediastinal lymph nodes. And then after starting ART a few weeks later, was found to be in pericardial tamponade, massive enlargement of the heart, needed to be sent to our cardiologist for emergency pericardial drain. And 1 liter was drained, and that was a 1 liter effusion that accumulated due to TB iris. So another life-threatening form of TB iris. And on the bottom panel was a patient who presented with pulmonary TB, put on TB treatment, then put on ART. Symptoms were improving, then they deteriorated after ART. You can see that the pulmonary infiltrate in the right upper zone gets worse. But what also happens is a new pleural effusion forms. Patient was short of breath. We started the patient on prednisone and also tapped their effusion with good symptomatic response. So you can get enlargement of effusions or new effusions forming due to TB iris. And this is just one underappreciated manifestation of TB iris, is it can involve the liver. Now, this makes absolute sense because TB iris affects patients with HIV and low CD4 counts who commonly have TB that disseminates in the bloodstream. And obviously, the liver is so well supplied in terms of blood supply that TB often seeds into the liver. It might be completely asymptomatic, but when patients develop TB iris, that can provoke inflammation in the liver. And this is just one example. Patient who had been on TB, this was a long time ago, a patient had been on TB treatment for 4 months for drug-sensitive pericardial TB. For some one or other reason, there'd been a delay to starting ART. Patient had improved, then started ART, and 3 weeks later presented with fever and a marked tender hepatomegaly. Patient had jaundice and very marked obstructive liver function derangement with a very high ALK+ and gamma GT, which is the typical pattern with TB iris in the liver. A CD4 count had risen on ART. The patient ended up having a liver biopsy, and it showed a large amount of granulomas in the liver. That was causing the hepatomegaly and the liver function, obstructive liver function derangement. The TB culture was negative. This is a common feature of TB iris is hepatomegaly and jaundice. The patients can have jaundice and obstructive liver function derangement. Obviously, very difficult to differentiate from drug-induced liver injury. Sometimes, if there's other features of TB iris that can suggest TB iris, but sometimes the patient needs a biopsy to differentiate, and sometimes you just need to be careful and treat it as drug-induced liver injury and see if it responds to drug withdrawal. But just to be aware that one of the manifestations of TB iris is tender hepatomegaly and obstructive liver function derangement with sometimes mild jaundice as well. But important to consider, is it drug-induced liver injury or is it TB iris, and seek expert advice. So the next point I wanted to make was that patients, when they present with TB iris, I've shown you all of the focal and the localized inflammation, but many patients also have features of systemic inflammation. This just from studies we did where we looked at the prevalence of features of systemic inflammation. 1/3 of patients had a fever. 70% of patients had tachycardia. So tachycardia is actually very common with TB iris. And one of the things that I've, as a clinician, have found is when patients present with TB iris, often they can have a tachycardia of 130, but seem completely well. It's not like patients with bacterial sepsis, where tachycardia often corresponds with how sick they look. The tachycardia can be out of keeping with how sick they look. Night sweats are common, and then patients can also lose weight just due to the inflammation associated with TB iris itself. And so the key points in diagnosing paradoxical TB iris, firstly, just to say the bottom point on the slide, which is there's no test which confirms a diagnosis of TB iris. It's a diagnosis of exclusion and a diagnosis of compatible clinical presentation. So the first thing you've got to ask yourself, am I sure that this patient is diagnosed with TB? Was the TB diagnosis confirmed, or is it very likely? So that you just want to be sure that that it's not because they've got an incorrect diagnosis. Then the question is, did they improve on TB treatment prior to ART, which is typically the picture? And is the symptom onset of inflammatory features of TB typically 1 to 3 weeks after starting ART? And then importantly, you've always got to say to yourself, this could be TB-RS, but what else could it be? And then exclude those diagnoses. So sometimes if patients present with breathlessness and a pulmonary infiltrate, you look at the chest X-ray and you say, I'm not sure whether this is TB-RS or whether this is a new pneumocystis pneumonia. And I'm going to treat for pneumocystis pneumonia first, or I'm going to treat for bacterial pneumonia, or I'm going to try and do diagnostic tests to exclude this. So you consider the differential diagnoses and exclude them. You might, for lymph node enlargement, think, could this be lymphoma, and then you need a biopsy to exclude that. I had a patient once who was referred with probable TB-RS at the lymph nodes. Now looked in her tonsils, and she had Kaposi sarcoma of the tonsils, and then Kaposi sarcoma in the lymph nodes. So just remember that there are many differential diagnoses, and you need to consider them. And also exclude, is this drug sensitive, drug resistant TB? Could the patient be deteriorating because they're not on the right TB treatment? So that's the approach to diagnosis. It's not easy. It's not like one diagnostic test. You need to work through it systematically. I'm going to go through this quite briefly, just to pick up on what is the underlying immune mechanisms driving TB-RS. And to firstly say that this is not simply a matter of recovery of CD4 T cell numbers, because sometimes we see patients with typical TB-RS and we check their CD4 count and it hasn't yet risen in the blood. And presumably they're developing TB-RS not because their CD4 count has risen in the blood, it's because there's been improvements in tissue immune function or improvements in monocyte function or other aspects of immune function before the CD4 count has risen. And many aspects of the immune system are involved, including acquired, like CD4 cells, and innate cells like monocytes and macrophages and neutrophils. The first clue that we got that TB-RS was due to improving immune function was from this interesting study that was conducted in Florida in the US in the 1990s, where they reported 12 patients who they said developed paradoxical reactions on ART that we now call paradoxical TB-RS. And 8 of them had initially had negative tuberculin skin tests. 8 had initially had skin tests, 7 of them were negative. So they were anergic due to poor immune function. And then when they repeated the skin test on ART, 6 of the 7 that had originally been negative had become positive, with a median size of 20 millimeters. So they hadn't just become positive, they'd become very positive. And one patient had a response of 67 millimeters, so 7 centimeter response. So what they saw was that these patients had deteriorated with inflammatory features on ART, but the skin test going from negative to positive and strongly positive was strongly suggestive of an improvement in anti-TB immunity that was underlying their clinical deterioration. And interestingly, these patients had no significant change yet in their CD4s in the blood, yet their tissue responses to TB antigen had substantially improved, going from negative to these 20 millimeter on average responses and up to 70 millimeters in one patient. What are the risk factors for developing TB-RS? It's obviously in patients with HIV-associated TB starting ART, and particularly if they've got those with lowest CD4 counts, the CD4 count is below 100 in particular, those with higher HIV viral loads, and then those with so more severe HIV with higher total body TB load. So patients with disseminated TB and extrapulmonary TB, they've got more TB antigen to provoke the TB. They're likely to be more likely that TB is culture positive, suggesting more organism. And there's a short interval between starting and starting. Those patients are more higher So there's one study on the right-hand side where they did PET-CT, which picks up inflammatory, metabolically active tissue, and those patients who had more PET-CT activity were more likely to develop TB-RS, and higher levels of inflammatory markers prior to ART, like IL-6 and CRP, are risk factors for TB-RS. And this is a very busy slide, but also all I wanted to say to you is that, we've done a number of studies looking at the immunology of TB-RS, and what we see is that even within the first few days of starting ART, we can pick up a gene expression signature involving cellular signaling pathways within cells like monocytes, like the inflammasome, which is inflammatory cascade found within monocytes, which amplifies the immune response. We find upregulation of genes associated with that. And then that sets off a whole inflammatory cascade, which involves cytokines, CD4 T cells, other T cell subsets, monocytes and activation markers in monocytes, and drives systemic inflammation and recruitment of immune cells to the tissue and tissue pathology. And this is if we do end up doing pathology on patients with TB-RS, which we seldom do, but if that happens, for instance, if a patient has a liver biopsy, we see extensive granuloma formation, and it's also been described when TB-RS involves the kidneys. You see granulomas in the kidney, and then you can also see suppurative necrosis, so neutrophil infiltrate, as in the patient with the large psoas abscess that I showed you. And in the CSF, interestingly, TB-RS is strongly associated with neutrophils rather than lymphocytes. So patients who have higher neutrophil counts associated with their TB-RS, with their TB meningitis, are more likely to develop TB-RS. And at the time of TB-RS, they get increases in neutrophils. So neutrophils appear to be a strong driver of RS when it involves the meninges. And this is just to show you that we've done a number of studies looking at the cytokines in the blood of patients at 2 weeks on ART, comparing those who developed RS compared to those with HIV-TB who did not develop TB-RS. And we see higher levels of cytokines like interleukin-6, interferon gamma, and TNF-alpha, suggesting that these cytokines are driving the systemic inflammation that we see with TB-RS. So that's just a little bit of the background immunology, and the main message is that the immunological features have been characterized, and it involves multiple components of the immune system, not just the CD4 cells. To go on to discussing treatment, our group many years ago did the only clinical trial that's ever been done for the treatment of paradoxical TB-RS. And it was a relatively small study that just involved 110 patients, but I think does provide the basis for treating the condition. We asked doctors at the primary care clinics to refer patients with suspected TB-RS to the secondary hospital. And if we did a diagnostic workup along the lines that I've shown you, and if we were convinced that the patient did have paradoxical TB-RS, as long as it wasn't life-threatening, we enrolled them and randomized them to receive prednisone or placebo. And the prednisone dose you can see there was 1.5 milligrams per kilogram per day for 2 weeks, and then half that dose for 2 weeks, and then stopped. So it was a total of 4 weeks of prednisone, 2 weeks higher dose, 2 weeks half that dose, and stopped. And the reason why we chose that dose, which is a higher than a usual dose, is rifampicin induces the metabolism of prednisone. So the effective dose of prednisone was lower than what you see there. But that's why we used that slightly higher dose. And when we compared the patients who received prednisone to placebo, what we saw was the primary endpoint was the number of days hospitalized plus outpatient therapeutic procedures like aspirations combined. And that was less common. You can see the p-value was 0.04 in patients who received prednisone compared to placebo. And there were similar number of deaths and similar number of severe infections in the study. So no increase in complications, but more rapid symptom response. And when we looked at things like symptom scores and chest X-ray scores and CRP, all of that improved faster in patients, and significantly faster in patients who received prednisone. So the conclusion from this study was, if you have a patient with TB-RS, you've done a diagnostic workup along the lines of what I showed you on the earlier slide, and you're now clinically convinced that this patient has TB-RS, they don't have something else, it's not drug-resistant TB, It's not, you've excluded other diagnoses that it could be. You think they've got TB iris, then they will get symptomatic response from the use of prednisone at a dose of 1.5 milligrams per kilogram per day for 2 weeks, followed by half that dose for 2 weeks. Sometimes patients need longer courses of steroids, but this is the standard dose. In terms of other aspects of management, generally we do not interrupt ART unless it's very severe and potentially life-threatening. We treat the symptoms like analgesia or antiemetics if patients have nausea, needle aspirates if there's a large effusion or painful suppurative lymph nodes that can give symptomatic relief. Nonsteroidals have been used by some people. I haven't used them, but some people have used them for milder cases. And in very protracted cases, biologics are used. And one, thalidomide has been used in refractory cases of TB iris with good response. Just anecdotal. Obviously, one needs to be incredibly cautious around the issues of its pregnancy and teratogenicity. But it is an option. And then things like TNF blockers and IL-6 blockers have also been used, but in only very rare steroid refractory cases. I just want to move on to discussing prevention. And the first thing that I want to say is, when you think about TB iris, one of the things that increases the risk for TB iris is starting ART early after TB treatment. And this shows you a meta-analysis of studies which compared generally starting ART 2 weeks after TB treatment to waiting to 8 weeks after TB treatment. What you can see is starting at 2 weeks almost doubles the risk of TB iris, or 17% compared to 8% if you start at 8 weeks. Now you might say, well, this is a strong argument for delaying ART in patients with TB if you can reduce the risk of TB iris. But of course, the flip side is that we do need to start ART early because it saves lives, and particularly in patients with a CD4 count of less than 50. So if this is the same meta-analysis, not looking at iris, but looking at mortality, and you see if the patients have a CD4 count of less than 50, and they start ART at 2 weeks compared to 8 weeks, you reduce mortality by around 30%. So CD4 count is above 50. There's no difference in mortality whether you start at 2 weeks or 8 weeks. But this means that despite the high risk of TB iris, we need to start ART early, patients with HIV-TB, particularly those with a low CD4 count. And this led us to designing a clinical trial that we did of using prednisone for TB iris prevention. So our rationale was that patients with low CD4 counts are at highest risk for developing paradoxical TB iris when they start ART. But initiation of ART around 2 weeks on TB treatment reduces mortality, but it also increases the TB iris risk by twofold. And at that point, there was no evidence-based intervention to prevent TB iris. So we knew that starting ART early saved lives, but it also pushed up the risk of iris. Is there something that we could do to prevent TB iris? And so we conducted a clinical trial of prednisone versus placebo for TB iris prevention, done in Kailicha a few years ago, with patients referred from 4 clinics. And this trial used a more moderate dose of prednisone because we were looking at prevention. So this just shows you the schema for the trial. The trial was called the PREDART trial. These were all patients on TB treatment, starting ART within 30 days of their TB treatment. 240 participants, all with a CD4 count of 100 less, and they were randomized to start ART with prednisone for 4 weeks and then followed up for 12 weeks, or to start ART with placebo for 4 weeks and followed up for 12 weeks. And what we were interested in, what was the rates of iris, comparing those who received prednisone to those who received placebo, and what were the rates of steroid side effects. And these were the enrollment criteria: adult patients never having been on ART, starting ART within 30 days of TB treatment, CD4 counts of 100 or less, and a range of exclusion criteria like rifampicin resistance, neurological TB, and Kaposi's. And just to focus first on the box on the right, the prednisone dose that we used here was a lower dose. It was a standard dose of 40 milligrams per day for 2 weeks, then 20 milligrams per day for 2 weeks. and started on the same day as ART to cover the first 4 weeks of ART. And what we showed was in patients who received placebo, the risk of, remember we were focusing on a high-risk group for TB iris. Those who received ART plus placebo, the risk of iris was 47%. Those who received ART plus prednisone, there was a reduction, it was 33% risk of iris. So overall a 30% relative risk of 0.7. So a 30% reduction in TB iris. So what it says is if patients are at high risk of developing TB iris, covering the first month of ART with this moderate dose of prednisone doesn't completely prevent TB iris, but it does reduce the risk. And those patients who develop TB iris on prednisone tended to have milder forms of TB iris than those who developed it on placebo. I haven't shown you that data, but in the paper we described that. And importantly, one of the concerns about using prednisone in these patients with advanced HIV is, could it cause more side effects? And we compared new AIDS-defining illnesses and invasive bacterial infections in those who received placebo versus prednisone, and there was no difference, no statistical significant difference between the groups. So it didn't increase the risk of severe infections. So that's what I wanted to say about TB iris. In the last few slides, I just want to mention that we do encounter other forms of iris in the context of HIV and starting ARVs. And you can see that this slide just summarizes a wide range of iris conditions that have been described in patients with HIV starting ART. Iris has been described in relation to mycobacteria. I've spoken about TB, but also Mycobacterium avium complex, leprosy. In young children, they can develop iris targeted at their BCG vaccination site and the associated lymph nodes. Fungal infections, I'll expand on cryptococcal iris. Then viruses like hepatitis B and C, you can get a iris targeted at them in the liver, causing a hepatitis flare. You can get iris targeted at a range of other viruses like herpes simplex and herpes zoster, protozoal infections, worm infections, and other skin conditions like acne. And then there's autoimmune manifestations, and even tumors can worsen like Kaposi's. So a very wide range of conditions has been shown to deteriorate or manifest or exacerbate in relation to iris during early ART. And then just to expand on cryptococcal meningitis iris, similar time course to TB iris. So these are typically patients diagnosed with cryptococcal meningitis. They started an antifungal treatment. Their headaches improve. They then start ART. And days to months later, median of 4 weeks, they develop meningitis symptoms again. Typically, the fungal culture in the CSF is negative because it's not a relapse of the cryptococcal infection. This is inflammation driven at the persisting antigens of Cryptococcus still present in the central nervous system. Typically, they have raised intracranial pressure associated with the cryptococcal presentation, and mortality is substantial at 20%. And this is just a case of a young woman who we saw with this typical course. She had a cryptococcal meningitis, was improving, started ART, and came in with recurrent meningitis symptoms, and then developed severe brainstem dysfunction. And you can see this inflammation surrounding the lateral ventricles and marked inflammation on the MRI scan in the brainstem, explaining her brainstem dysfunction and her brainstem signs. And she responded very well to steroid therapy. And this is just an example from a presentation that I saw from Uganda of a patient who had Kaposi's sarcoma and started ART, and you can see worsening of the Kaposi's lesions and new lesions forming as well. So Kaposi's can worsen as iris, and the treatment of this is with chemotherapy for the Kaposi's. And then finally, there are a number of skin conditions that can worsen due to iris. And this is just one young woman who might have had some mild molluscum that was missed, but she started ART and then presented with a florid molluscum rash in the first few weeks of ART, and we labeled this as molluscum iris. And I've also seen patients with acne worsen on ART, which really makes sense because acne is partly an infective condition, And within the pores, the Propionibacterium acne bacteria, and you develop an immune response to that, and the acne can worsen and form pustules. And the treatment of that is with doxycycline. So then, just to wrap up, just to summarize what I've told you about TB iris, and specifically paradoxical TB iris, which is the main in a pooled incidence across studies of 18%. So 18% of people on ART, on TB treatment starting ART will develop paradoxical TB iris, but it occurs in some studies up to 50% if you're looking at patients with a lot of high risk factors. Those risk factors are patients with very low CD4 counts, with extra pulmonary TB, and a short delay between starting TB treatment and starting ART. But as I said, we can't afford a long delay, particularly in patients with low CD4 counts, because we need to start ART early to save lives. Pulmonary and lymph node presentations are the most frequent forms of paradoxical TBRs, and I've shown you examples of those. Central involvement can be fatal, and that's a reason why we did delay ART in this setting to 4 to 8 weeks if there's TB meningitis. Multiple components of the immune system contribute to the underlying mechanism, and prednisone is partially effective and safe for both the treatment and the prevention of TBI. So I'll show you the treatment dose that we tested in the trial that led to a more rapid symptom response, 1.5 milligrams per day for 2 weeks, then 0.75 milligrams per day for 2 weeks, but only use prednisone to treat TBIs when you're clinically sure of the diagnosis, because you don't want to be treating another condition that you mislabeling as TBIs with prednisone. So be sure of the diagnosis first. And for prevention in high-risk patients, the dose was 40 milligrams per day for 2 weeks, followed by 20 milligrams per day for 2 weeks, also just 4 weeks. And then just to finally acknowledge the many colleagues that I've worked with on the studies that I've shown and the funds of our research. And thanks again, Lisa, for the opportunity to present.
Thank you very much, Prof. I think, yeah, it's very interesting. I have learned so much today. Colleagues, do type in your feedback in the chat and use the Q&A tab for your Q&As. And yes, we see all your emojis. Prof is the modern era. I think we embrace this feedback. I think we will go through some of the questions on the Q&A. I just wanted to start by maybe posing a question to you, Prof, to say, in terms of differentiating between paradoxical versus unmasking iris, how important is that process in terms of how you respond to your patient clinical, in terms of the process? Yeah.
Yeah. So obviously, as I said, it's the sequence of events that helps you to differentiate. And if it's paradoxical TBRs, the patient's already on effective TB treatment, so you've already got that angle covered. You've started them on ART, and they're now deteriorating. And if they've got significant inflammation, you're sure of the diagnosis of TBRs. In that context, prednisone or steroids are going to give symptomatic relief. Okay. And it's really, you're treating for symptom relief. With unmasking iris, then you've got a patient who is not yet on TB treatment. You start ART, then you diagnose the TB. So then the priority is to start them on TB treatment first, before you consider steroids. And they might well do well just on TB treatment. But if you would then see them again in 1 week's time and 2 weeks' time. And if they got ongoing inflammation, only then would you consider steroids. So really the difference is with unmasking TB iris, the priority is to get them to make the diagnosis of TB and start the TB treatment and then follow them up. With paradoxical, you've already got them on TB treatment, you've got them on ART. The question is, do I need to add steroids? And you add steroids when you're sure of the diagnosis clinically, and they've got significant symptoms. I wouldn't, like, if a patient is just complaining of a recurrence of night sweats and a mild cough, I wouldn't necessarily start them on steroids. Because steroids do have side effects. It's significant symptoms that you're wanting to treat. Yeah.
So just as a follow-up, the patients who had pulmonary TB and they were started on ARVs and now they are presenting with TB on another system, like a meningitis.
Yeah.
How do you explain that? Is that was it subclinical in the meninges or what happened?
Exactly. I think the way I think about it is that
Mm,
this is a condition that affects people with very low CD4 counts and very poor immune function. And
mm,
these patients, when we see them in the clinic or in the hospital, often we diagnose the TB at one site and we label them as having pulmonary TB or TB in
mm,
the lymph node. But what we don't appreciate is often the TB has spread into the bloodstream and spread to multiple organs. But
mm,
because there's such poor immunity, it's not manifesting because you need an inflammatory response to cause a lymph node to enlarge or to give you inflammation in the meninges and meningitis symptoms. So the
mm,
lack of an immune response means that organism get to those sites and not cause replicating there. It's only when you get that improving immune function that drives inflammation that
mm,
you can develop deterioration with TB iris, and then it manifests clinically. So it's exactly that you've got subclinical involvement, which
mm,
just manifests once once you get the inflammation at the site driven by iris.
mm. Yeah, and then in
I mean,
terms of
I would just say, just to really
yeah,
emphasize
yeah,
that point,
mm,
I always used to think cryptococcal meningitis was just a disease of the meninges,
mm,
until I was involved attended a few autopsies of patients who had died of cryptococcal meningitis. And I realized that patients who have cryptococcal meningitis, the cryptococcus is often everywhere in every single organ, and
mm,
yet they don't manifest inflammation because they've got such low CD4 counts. And so it goes completely subclinical at the other sites. And that's the same thing with TBR until you get the recovering immune response,
mm,
and that drives inflammation and clinical manifestations.
mm. Prof, whenever I teach, I always tell people that I love iris because it tells me that the patient is taking the ARVs and the treatment is working. And
Mm.
sometimes people look at me, they're like, no, no one likes iris. Are there any benefits of iris and these cytokines that are being generated? Is it
No,
always bad? Yeah.
I think it's well, the benefits are that people are going to be are taking the ART, and in the long term they're going to get recovery in the immune function and live a lot longer. But this is a
Yeah.
nuisance. It's a real nuisance. It's almost like you have to go through this bad patch to experience the long term real positive benefits of immune recovery. But this
Mm,
early phase of immune recovery in the context of a pre-existing opportunistic infection is just one of the nuisances,
mm,
and sometimes it's more than a nuisance, as I showed you, that it can be severe in a
mm,
small proportion of patients, but often it's just a nuisance. It's a deterioration. Patients treated symptomatically, sometimes with steroids for TBRs, and just get them through this for the long-term benefits. And I guess it's the long-term benefits that this is all about. Yeah.
yeah. Yeah. All right. There's one more. The scenario where the patient had, I would say, disseminated TB to the liver with the granulomas. I find that
Mm.
when we do our visits to district hospitals, clinicians struggle to differentiate between a hepatitis versus not even
Mm.
a hepatitis. Let me say whether this deranged liver enzymes they're looking at, is it an iris or is it a drug toxicity from the TB drugs? Like,
Yeah.
yeah, I don't know if you
Yeah.
follow what I'm trying to
No,
get
well,
to. Yeah.
yeah, yeah. Let's say, I mean, the honest, the truth is, there are many cases where I have struggled as well. So it's not
Mm,
a clear cut thing. I'm not suggesting that it's clear cut.
mm,
What what we must remember is that several of the TB drugs that we use, rifampicin, INH, and PZA, can cause drug-induced liver injury.
mm,
Cotrimoxazole is a rare cause of drug-induced liver injury. Fortunately, today the ARVs are less hepatotoxic than they used to be, so that's no longer an issue. So you've got the TB drugs mainly, and then you've got TB iris. And what I would say is if it's mainly involvement of the transaminases, so the ALT and the AST are in the hundreds, that suggests more DILI. And if it's mainly obstructive picture, that's more like suggestive of TB-iris. If there's tender hepatomegaly, that's more suggestive of an iris. If there's severe jaundice, that's more suggestive of a drug-induced liver injury. If there's mild jaundice, that can be due to TB-iris. If there's features of TB-iris elsewhere, that suggests the diagnosis of TB-iris. But I've often been, seeing a patient, I'm not sure. It's somewhere between those two. Yeah. And then what I would do is to first then interrupt the treatment, treat as a DILI, and assess the response. The honest truth is sometimes it's very difficult to tell the difference between the two. And in that situation, treat as a DILI and then see what the response is. Sometimes if you can access a biopsy, sometimes that's necessary, but I'm aware that in many settings that's not possible.
Not visible, yeah. But I think the case, the way it was presented, I saw the GGT and ALP were quite very high, but your AST and ALTs looked fairly, should I say, normal? I couldn't check it
exactly.
quickly.
So it was twofold, twofold ALT and AST elevation, a mild jaundice, tender hepatomegaly. But you can see even, it was an old case, but even our liver team felt they wanted to do a biopsy to be sure. So, it's not easy. Sometimes, the safest thing is to treat as a DILI and assess the response. And if it doesn't respond, then it's more suggestive of TBI.
Then I listened very carefully to some of your slides. The need to sort of confirm that this is not like the TB is not active, because there's a question about TB iris unmasked versus reactivation TB. And I saw you were mentioning AFBs and cultures. Would you like to clarify that further? Yeah.
Yeah. So I mean, I think this is particularly patients with like lymph nodes or abscesses. And and they go, those can sometimes go. What I didn't say, they can sometimes go on for months, and then you're asking yourself, am I dealing with an iris, which is an immunological phenomenon, or is the patient failing their TB treatment because of drug resistance or because of malabsorption or poor adherence? And there, what can be useful is to get a sample from the pus and send it off for TB culture, because if the TB cultures are negative, that reassures you that this is an immunological phenomenon.
Super, super.
So, it's not something that's going to help you on the same day. And I'm not suggesting you do it in every patient, but it's those patients where it goes on for a long time. You just want to make sure that the TB treatment is working and that it's culture negative. If it's culture negative, then it really strengthens your suspicion and the reliability with which you say this is iris, this is an immunological reaction rather than failure of TB treatment. So that's where the culture comes in.
Super, super. And I see also a theme in terms of this question, do we stop ARVs or not? So maybe the question to you, Prof, is when would you consider stopping? Yeah.
So look, I mean, I would say in 99% of the people I see with TBRs, I do not stop ART. I would stop it if patients have life-threatening neurological phenomenon. And mainly try and treat through and with high-dose steroids if necessary, but not interrupt ART. I think once you've got a very severe form of iris, whether stopping ART does any benefit, I'm not sure. But if the patient is like as a severe cerebral edema and depressed level of consciousness, that's a situation where I would stop ART. Or you start steroids and they're not responding and it's life-threatening, then I would consider stopping ART. Whether it does any benefit or not, I don't know. I mean, I showed you a case where we stopped ART and the patient died nonetheless.
Yeah, you remind me of my early days in a rural setting where sometimes I was caught not being sure even to start art because I remember there was a Kaposi patient and I was trying to book them for Pretoria and they gave me a date that was very fast. So I was not sure, should I wait for that date or should I start the ARVs? Because I was worried that I would start and the patient would come back with, I don't know how many lesions, you know.
Yeah,
But then the date
yeah,
for
yeah,
chemo is like, I don't know, 4 months ahead. I don't
yeah,
know if the colleagues still experience that. But I would start, and the majority of patients would do well, but there'll always be one where I feel,
yeah,
yo, maybe I could have waited. Yeah, you know, the
yeah,
health
yeah.
can be quite challenging, Prof.
Yeah,
Mm.
but let's say, if I reflect on sort of over 2 decades of experience in the ARV program, I think a lot more people have died because of clinicians' fear of iris and
Yeah, yeah.
delaying AR than people who died of iris. Because remember, the majority of people don't develop iris,
Mm,
and the majority of people who develop iris survive nonetheless. And I think as clinicians, we often are more scared of the things that our actions will cause rather than our inactions will cause.
mm,
Because you always feel guilty about, I started ART and the patient developed iris. You don't
mm,
feel guilty. The patient, I didn't start ART. The patient went home and died at home. It's we remember the issue, the problems that we cause by our actions far more than the delays and the inactions. So that's what I would say is, if you have a bad event starting ART, don't let it influence you, because the amount
mm,
of benefit that you do from getting in and starting ART and particularly patients with low CD4 counts far outweighs the risks of iris. So I don't want to, leave people with a terrible kind of
mm,
impression of that one case on a slide, of a
mm.
single patient. I think it's far more important to remember the huge benefits from just getting on and starting ART in people with advanced immunosuppression. And there might be some problems in some patients, but delaying ART and not starting, there are many patients who go home and die at home, and we never know about that. And probably, it's just not on our radar the way iris is, and we shouldn't, we must just balance those two things when making decisions.
Thank you. Thank you. I think that is important and very, very reassuring. Prof, regarding the use of steroids for prevention or yes, for prevention of iris, does it matter as to whether the patient has DS versus DR TB?
Yeah, look, those studies were both done with only in patients with DSTB, and they were done in an era in which we didn't have a good treatment for drug-resistant TB.
Mm.
Remember that, they were done in an era where we were still using amikacin and ofloxacin, and
Injections.
I, we didn't, because we weren't confident with those TB treatments, we didn't want to give those patients steroids. But I think
Mm.
if you had to ask me what I would do today, if I've got a patient who's on effective MDR treatment, I know their sensitivities, and I'm confident that they're on effective TB treatment, and they develop iris, then I would give them steroids, because I'm far more confident in drug-resistant TB treatment today. As long as people I know that they're on an effective regimen than I was in those days. But those trials didn't include patients with DRTB.
Super, super. And Christopher is asking a very interesting question. He says he saw two patients with TB iris who were HIV negative and is
Mm.
asking the pathogenesis is the same and the
Yeah, yeah.
clinical approach. Yeah.
So I mean, just as a matter of terminology, I don't call that iris, because it's not that they experience immune reconstitution,
Mm,
but I call them paradoxical reactions. I think
okay.
people call them paradoxical upgrading reactions is the other term. And what we think is that you can get patients, yeah, who develop particularly lymph node TB, HIV negative people. They start their TB treatment, and a few months into treatment, their nodes start enlarging, and that could be due to the mycobacterium being killed and releasing antigen and provoking an immune response. could be also that there was some immunosuppression from TB itself from which they're recovering, that adds to the pathogenesis. But that's been poorly studied, and we don't. These are just hypotheses. We don't really understand it, but it's a similar phenomenon. One thing I would say about those paradoxical reactions in HIV negative people
Mm.
is they tend to be focal, just at one site, and
Okay.
without the systemic inflammation that you see with TB-RS. So
Okay.
it can be an enlarging lymph node or a meningitis or an enlarging tuberculoma in the brain, but it's just at one site. They don't have the tachycardia, they don't have the fever. It's just the inflammation at one site.
Mm. Mm. We are empowered, colleagues. And colleagues, why do you want to become anonymous? Don't be anonymous. We want to call you by name. But anonymous has something I haven't seen in a while, but it's still there. It says he or she is currently managing one CMV retinitis who presented with blindness 3 months post ART initiation. And the patient is now 1 month after starting valagencyclovir. I don't know which, yeah. And then it says the patient is still blind and is trying to see if there's anything they need to do. I think this is just confirming that you can have iris from almost any infection. And I know, Prof, there's also non-infectious forms of iris. I've seen people with tattoos and other things. Yeah, I don't know. Any comments from your side around CMV retinitis?
Yeah, it would very much depend. What's been reported in the literature is that CMV of the eye
Mm,
can either manifest or worsen after starting ART. And that can either be a retinitis or it can be a more extensive inflammation, a uveitis,
mm,
involving the whole of the posterior chamber. And clearly the first thing to do is to make sure that the CMV is optimally managed, and that seems to be the case here with the valganciclovir. And then the question, is really an ophthalmological one, whether intravitreal steroids would have any role, but that would be after if there's a more generalized uveitis, not for retinitis alone. Steroids
mm.
would have no role if it's just retinitis alone. But if there's more extensive inflammation, there might be a role for steroids, but that would be outside of, I would defer to an ophthalmologist to make that decision.
Yeah.
And unfortunately, with retinitis, often there's necrosis, and there's no improvement if there's permanent damage from necrosis, retinal necrosis, and
Super.
retinal detachments as well. Yeah.
All right. Prof, can we take the last two questions and then
Sure,
maybe
sure. Yeah.
we close up? So this one I don't know because there's a lot of questions about children and people asking whether the protocols around prophylaxis or the approach is it the same. I don't know if any of your studies included children. I suspect not. It's
No,
not common.
I haven't
Yeah.
managed children or done any research, but I've obviously interacted with a lot of
Mm,
pediatric colleagues. There've been no clinical trials of TBRS in children, but generally it tends to manifest very similarly, with the
mm,
same, with lymph nodes, pulmonary, central nervous system, same kind of manifestations. And when children have significant symptoms, they have been treated with steroids, just with weight adjusted, using similar kind of doses as adults, but obviously adjusted for to be appropriate for their weight.
mm.
I've not heard that they've used it for iris prevention though. And one of the difficulties with TB in children is confirming the diagnosis. And so, when you're using steroids, you want to be confident about the diagnosis. And I think that makes it more difficult in the context of pediatrics. If you're not sure of the diagnosis of TB in the first place, you don't want to
Mm.
start using steroids. But if you've confirmed the diagnosis of TB, and then you get a typical iris and you're confident of that, then I think there is a role for steroids. But sometimes it's less clear because of the diagnostic difficulties.
Yeah, thanks, Prof. Okay, I saw a number of questions about primary health care. maybe, yeah. So what would be the role, maybe let me put it like that. What would be the role of the DMARC nurse in this instance, Prof? Because there's a number of people say, I'm working at primary healthcare. What should I refer all? Is there something I can do? How would you advise? Yeah.
Yeah, I think clearly many of these patients are going to be managed by our NMARD colleagues. And
Mm,
I think the role is to just be aware of the condition and its many manifestations, and we've discussed that tonight.
mm,
To discuss it with patients, and discuss those at risk, and explain to them what might happen, and counsel them about if it occurs, then this is what is happening, and don't be overly concerned, but come back and we can discuss it. And if it's a clear-cut case, then it can be treated with TB with prednisone. If it's, you can see that sometimes there are diagnostic difficulties, and then to be discussed with a doctor, and get a diagnostic plan, and then a management plan, similar to what I've discussed tonight. So I think awareness of the condition, patient education, and approach to diagnosis, workup, and discuss it with a colleague if there's any uncertainties. And it's not an easy, it's not a straightforward diagnosis, because there's no diagnostic test, and it really needs colleagues to interact and discuss, and to think about the diagnosis. And that
mm.
applies equally to NMAT colleagues and to medical colleagues. Yeah.
Super, super. Prof, the last question. I saw a number of people asking whether if someone has iris, do you need to extend the duration of treatment for TB? But let me read Kulile's scenario. It's still the same question at the end, but he has
Mm.
given he or she has given it. Says they have a 39-year-old patient who was started on TB treatment because the gene expert was positive and RIF was sensitive. So I started on RIFA 4, and then 4 weeks down the line, the patient was started on TLD, the CD4
Mm.
count was 37. And then later, the patient, I think 4 weeks later, after starting ARVs, the patient had a spontaneous pneumothorax. So firstly, that's my question.
Mm.
Can iris go that far? Because that is the first question. And then he's also asking if they should extend the intensive phase. But the AFB and cultures at this point of the pneumothorax were negative. I find it
Yeah,
interesting.
I think
Mm.
I've once seen it cause a pneumothorax.
Oh.
I mean, you would, if there's a significant inflammation in the lung, and
Mm,
some tissue destruction, that would make sense that it could cause, but you would have to see what the X-ray, it could be unrelated to iris. It could just be, we know TB itself,
mm,
if if there's destruction close to the pleural surface, that cavity can rupture. So whether it's iris or not, I would want to see the chest X-ray to see, is there worsening inflammation that has given rise to the pneumothorax formation. So it's not common, but yes, it is possible. But generally, iris is not a reason to prolong the intensive phase or to prolong TB treatment.
mm,
Sometimes if patients have these prolonged abscesses, we do prolong TB treatment.
mm,
And that's just to wait for the culture results, and just to see that multiple cultures are negative.
mm,
And it's, sometimes if the patient's got a massive tuberculous abscess, it's difficult to stop their TB treatment, until that's clearly improving. But most cases of TB iris, you don't need to prolong the TB treatment or the intensive phase. And as I say, pneumothorax, it could be due to the iris, or it could be just due to the TB destruction that was there anyway. And I'd want to see the chest X-ray to make a decision about that.
yeah. Thank you. Thank you. Thank you very much, Prof. Very, very awesome. I can assure you that I have learned a lot. You at least have one person who has been transformed by your topic, and that is me. But I do know for a fact that there's a lot. Colleagues, just to thank you for joining us this evening. Otherwise, it would have been me and Prof only. I don't know how that would go. But before I ask Prof for his closing remarks, I wanted to say check the chat. Colleagues, I've shared a number of links. Firstly, the early breast cancer short 2 CPD course. It's open to everyone. Anyone who's interested, please complete it. Also to say that the diploma preparatory programs are live. And for the internal medicine guys, we go live now at 8 o'clock. We don't sleep, we push. And yeah, just to appreciate you, we had actually crossed over 1,000 people attending. I just wanted to say thank you for making time and for committing to your professional development. Prof, your closing remarks, and we call
Yeah,
it.
thanks, Lesego. And as I said, thanks for inviting me on the platform again. I really appreciate it. And I'm really excited that there's over 1,000 people interested in iris because I've been fascinated by the condition for the last 2 decades. And great to be able to share some of the research that we've done and some of the data around iris with such a large group of people. Thanks very much.
Thank you. Thank you, Prof. We appreciate all your work and we are implementing it to improve patient care. May I wish everyone a restful good night with your families. Bye.
Bye bye. Thanks, Lesego.